Apologies for that. The technology is so high level. The old computer they're working there is crashing. So the computer, but we'll be out in the next 5 seconds. Someone that needs to be around people in your pockets can help us. SAROVA needs to be around people.
German one. This one is German. As in, I thought this is 5 minutes. I've realized.
Don't jama.
Thank you.
The best doctor now because
What you are for?
I'm for electrician. I'm an electrician.
Electrician. Where is my plug, Baba?
What?
Plug, multi-plug to arrange the TV. Come here. Check where is the multiply to
This one.
Done. Okay, fine. Thank you. Fine.
Okay.
Thank you so much.
Welcome.
In this video, you can see the latest technique. So first of all, you see the opening of the cyst and the washing with saline solution, and then we are using here on the right the laser. So we are making the ablation by laser. It's so important here to keep the distance with the tissue. So we try to keep the distance 5 millimeter distance in order to be effective. But you can say in a distance between 0.5 and 1 centimeter. So half a millimeter, 1 centimeter. It's okay in order to make the superficial ablation of the inner wall, inner surface of the ovarian cyst. On the other side, we are performing the stripping, and you see how it's more complex and traumatic also for the patient. So it's a surgically complex neck. And you know that the cystectomy reduces the number of follicles post-surgery. And also the recurrence rate is between 9 and 20%. Indeed, what we saw during our study is that the recurrence rate is very, very good. We had very good results because we had a recurrence rate less than 6%. I'm trying to move forward. Please, can you start with this video? Thank you so much. So in this case, you can see better our technique. So after removal and aspiration of the chocolate liquid, we proceed with the laser vaporization. The distance action, and usually we start from the middle, from the center, and we describe a circle. Why? This is a tip. We think that making like this, we try to avoid any recurrence, or we try to cover all the superficial work, and so we reduce the recurrence rate. That's all. Okay, coming to the outcome, this is so important because we evaluated the AMH, so the antimullary hormone level, at 3, 6 months and 1 year post-surgery. You can see here that this picture shows a significant difference from baseline. So after 3 months, the level of antimullary hormone goes down significantly. However, there was a return to nearly the surgical value 6 months later and 1 year later. So there are no statistically significant difference between the level at 6 and 1 year later compared to top line. So this is so important. But more important thing is the next outcome. Please one, please. Okay. No. Thank you. This slide shows the intrafollicular count. What does it mean? the number of follicles, and we compare the number of follicles baseline with 3 months, 6 months, and 1 year. And here we can see that the operated ovary shows a significant increase of the anthrofollicular count after the later procedure. At 3, 6 months, and 1 year later. On the other hand, there were no significant difference observed in the anthrofollicular count on the contralateral, not operated ovary at baseline 3 months, 6 months, and 1 year after surgery. So what does it mean? It means that the laser was absolutely gentle and respectful of the ovary. But at the same time, with this technique, we completely destroy the endometriotic tissue, the endometriotic cell. So we can move forward. Okay, outcome number 3. What the study say at the end. So this is my conclusion. We had roughly the 50% of infertile women that became pregnant after laser treatment. It is amazing. Also, the number of recurrence rate was only 6%. This is also a very surprising information during 1 year follow-up. This value is absolutely positive because, you know, if we are comparing with stripping, the cystectomy is associated with a recurrence rate between 9 and 22%. So our results were absolutely good. Instead of comparing the other technique, ablative technique, for instance, the sclerotherapy and the CO2 laser, the recurrence rate were 11.8%, so 12%, and 13.5%. Last but not least, in this my conclusion, we can use the same technology also for other applications. For instance, for laparotomy or for hysteroscopy or for cosmetic gynecology, for instance, for the treatment of vaginal atrophy and the mild urinary incontinence. Also for laparotomy, but is video working? You are not happy with the video.
Please prepare your questions. Please prepare your questions. Okay, we are having challenges with people. Yes, we have the second presenter. Please, can you talk for 5 minutes, and then we'll have the question. Please prepare your questions. I think this is a very interesting technology, and I'm sure the laparoscopic surgeons and others, because you can see the technology can be used also in the laboratory as well. It will be an interesting approach to our patients. Please, you have 5 minutes. Thank you.
Good morning, everyone. My name is Binoy Thomas, and I'm a product manager at BioLighter. It's a truly pleasure to meet you all today. I would like to extend my sincere thanks to KOGS and even organizer to giving me the opportunity to share the insights on BioLighter innovative therapy, laser therapies in gynecology. So I will just take only 5 minutes to just introduction about BioLighter and what is BioLighter products, what we handle. BioLighter is a German company. We manufacture laser machines and fiber optics for different applications. Headquarters in Vienna and factories we have in Germany and Latvia. So our presence are more than 100 countries with our partners, and BioLighter manufactures the laser machine. Is a diode, is a Leonardo laser with a different type of wavelengths, as Roberto has mentioned that in gynecology and laparoscopic applications, we can use 1470 nanometer and 980 nanometer combination with the different high power lasers. The 45 watts, we have 200 power lasers also. So basically, it's suitable for a wide range of applications in the field of gynecology. We can use it for vascular surgery. We can use it ENT, coloproctology, urology, PLD for spine treatment for herniated disc and for the thoracic and hypothyroid. So, as I told you, this laser machine works, have a two wavelengths. One is 1470 and one is 980 nanometer. It ensures the high absorption in water and hemoglobin, and modern compact design and choice to various power generators on multi-modality applications. So we can use it in multiple applications. What is in 980 and what is in 1470? As you know, everybody, there are a lot of lasers are available, and many of surgeons are using in Kenya or in other regions. They are using lasers for different applications. Maybe I can say just very simple. So, you know, it's hexagonal laser, argon laser, NDR laser, Holmium laser, 1470 nanometer laser, 1940 CO2 laser. I believe everybody knows very common term is Holmium laser, especially using for urology applications for stone straightness. So when it comes to 980 nanometer, it's equally absorbed by hemoglobin and water. But when it comes to the 1470, the absorption rate is higher than the 980, that is 65 times than the 980 nanometer. So this slide, I believe everybody knows. When you're using a cautery, monopolar cautery, when you're using it to cutting the tissue or a coagulation, what happens is, and you go to the last one, it's the penetration depth deeper side. Yeah. So what happened is, the penetration depth is deeper. Second, it's too much necrotic tissues, you can see that. But when it comes to the laser, as I told you, 980 nanometer or 1470 nanometer, we have certain powers when you use it for each application. So the penetration depth is less compared to the conventional technique. So the advantage is there in the laser. Second part, not only the laser benefit which you are getting, you get in the fiber. We have different type of fibers. So when it comes to the conical tip fiber, or especially in the cylindrical tip, so you can see the penetration depth. So when it comes to 980 nanometer, the penetration depth is approximately 4 to 5 mm. If it is a 1470, approximately by 2 mm. So we have a fibers contact, that works in a contact mode, and non-contact mode also. We can vaporize and coagulate. These are the different type of fibers which we use in different applications, which I explained to you earlier. When it comes to gynecology, our applications, we can treat it for HOLA, histoscopic outpatient laser, for treatment of polyps, myomas, septum, and isthmosis. When it comes to ELA, that is endometriosis laparoscopic laser application, for the deep inflated endometriosis, ovarian endometrioma, salpingectomy, ovarian cyst, we can treat for the laparoscopy. So when we have another third application, that is Lavita, we use for laser treatment for genitourinary syndrome on the menopause, vaginal atrophy, and mild stress incontinence. So BioLighter is, we are in the different field. It's in the gynecology, coloproctology, phlebology, urology, bladder tumors, DCRS, orthopedics, ENT, thoracic, thyroid. These all applications we can use with one laser. That's an advantage in the BioLighter, because we are using the same laser. It has 980 and 1470. We can choose according to the procedure. Some of cases will be 980, some of cases will be 1470. So to conclude, BioLighted, as I told, it's a full range of applications are there, and now these fibers and machines are available in Kenya. So through our trusted partner distributor, Mediglo, we are supplying the fibers and machines. For more information, to explore our products further, please visit our booth. We have a booth here, so booth number 22. Thank you so much.
Thank you very much, Timo. It was actually less than 5 minutes. Do you have any questions? As you prepare your questions, I'll ask Roberto, please. I think I have 2 or 3 questions. Question number 1 is about the vaporization effect, which you mentioned, and how near the bounds can we use this laser? Because sometimes we see patients who have endometriosis, complicated endometriosis, sometimes it's going to the rectovaginal fold, sometimes it's on the bladder, the ureters. How safe are we when we use it to dissect the adhesions? That's question number 1. Number 2 is how far from the tissue should the diode laser be when we are doing the vaporization? Number 3, outcome number 2 was very important. It was very interesting to me because you say 6 to 12 months after the vaporization, the antral follicle count actually increased, and you showed that on your graph. I'm just wondering what the explanation could be. And then lastly, the AFC, antral follicle count, prior to the surgery, did you use the 2D ultrasound or did you use a volumetric ultrasound? Because then you can actually automatically calculate how many antral follicles you have in the sizes as well.
Thank you for this question. There are 2 absolutely interesting questions. So, basically, we have a technology that allows us to select the right parameter for the right indication and the disease we need to treat. So, for instance, for the endometriotic nodule at the level of the bowel, we need to be absolutely superficial. So that's why we don't want any kind of damage, and so we are able to select the laser in a very superficial action. Consider that you have a machine that has presetting. So we have the preset for the endometriosis at the level of the bowel. We have the presetting for the treatment of endometriosis at the level of the ovary. So we are using different protocols, different settings in order to get the best result and to have a minimal risk, a minimal contraindication, of course, to reduce as much as we can the risk during the surgery. Say that I can confirm that the penetration that is less than 1 millimeter, keeping the distance through to the tissue. So keeping a distance of half a centimeter, 0.5 millimeter. Half a centimeter. We can have this penetration. So penetration less than one millimeter, 0.8 millimeter. So it's very superficial. Coming back to your second question, I believe it's so interesting. I showed you that the antral follicular count increased. The number of antral follicular increased after 3, 6 months, and 1 year. The explanation should be because with the laser we are treating also the inflammation, and so we are able to see better with the volumetric ultrasound the number of follicles. Generally speaking, we improve also, or at least this is what we think. Of course, we need more data to say that, but it's only one theoretical evaluation. We believe that also the quality of follicles became better after the reduction of the inflammation.
Thank you. Maybe one or two questions from the floor. Yes, Professor Suman. And there's another hand up there, please. We are just two questions. The other ones, please, you can go to your two questions. Professor.
Nice to hear your questions. In our part of the world, first factor is the deepest. So if the fertility is not the issue, we will still recommend using laser instead of this conventional steeping technique. One is that one. Next one is I missed out of what do you have that competitive outcome while suturing with the using the laser in view of again the retention of the AFC count or indirectly over user and or ANC. Thank you.
You're welcome. Thank you for your question. And of course, we recommend actually this technology after this publication. We can say clearly now that it's safe. Of course, you need to be trained, but you don't need so long training because usually it's very easy to use the laser than to make the cystectomy. So for our experience, we can say that even for a beginner, it's possible to use the laser. Of course, you need to have in mind some parameter. You have to use the right setting, and you have to. This is so important to respect the distance with the tissue, because what we saw is a non-contact treatment. So if you respect the right distance between the laser beam and the tissue, you can be sure that the penetration that is right. Indeed, actually, we don't perform anymore the biopsy after, or we don't evaluate anymore the depth of the laser at the level of the ovarian treated. Coming back to the question, we didn't put any stitch after the laser vaporization, so we leave the ovary like this. Even because what we saw is that after the use of this technique, the laser, on the ovary, we saw a shrinking, natural shrinking of the ovary. So usually we don't need to put any stitch after the technique.
Last question, please.
When you guys did the study, did you guys compare the outcomes and fertility outcomes between those and traditional? And then also, did you compare complications between the two?
Speaking of complication, we don't have complication. We didn't have complication at the moment. We had, we created 7 patients here, but at the moment, after 4-year experience, we had more than 400 cases performed with this technique, and we had no complication. Recurrence rate, sorry, is pregnancy rate is 48%.
Compared to traditional, were they similar, or was there a big difference between doing like a cystectomy versus the laser?
Okay, well, compare with cystectomy, we didn't make any comparison, but only this is the result we had on after the use of on laser. Okay, so we didn't make any randomized clinical trial, and we didn't compare for the moment the pregnancy rate between laser and the cystectomy. But I can tell you that this is the result we obtained after the use of laser only. Mono and we did the monolateral and bilateral.
Thank you very much, Roberto, for that very interesting presentation. And I think this is part of the armamentarium which we can use to be able to assist our patients, especially when we talk about endometriosis and endometriomas, basically. And I'd like to thank you for taking part